Can you see the PowerPoint?
Yeah.
Can you hear my voice?
Yes.
All right, so let's begin. So, connective tissue diseases, SLE. So for this one, SLE, it is a chronic inflammatory disease with genetic, environmental, and hormonal factors. In terms of epidemiology, for your SLE, women accounts for about 90% of cases. African American patients more frequently affected than Caucasian, milder in elderly patients, more severe in children, and it appears in late adulthood or adolescent. The types, they're there, you can read that. So I just wanted to know clinical findings associated with neonatal lupus in the neonate, the newborn. You can see skin lesions, cardiac abnormalities, and valvular and septal defects. There's a lot of features. I wanted to focus on the Raynaud's phenomenon and the Liebman-Sachs endocarditis, which is a complication for your SLE. You can also have some renal nephritis for SLE. You can read all of that. How do we diagnose SLE? So ANA, it's sensitive. However, the most specific one is anti-double-stranded DNA and anti-Smiths. These are very, very specific for SLE. So don't forget, doctors, the clinical course of SLE, they're chronic. They're characterized by exacerbations and remissions. So what can we see? A typical patient, malar rash, joint pain, and fatigue. With more advanced disease, you now have renal involvement, pulmonary, cardiovascular, and nervous system affected. High-yield antihistone antibodies for drug-induced lupus, and the RHO and LA, or SSA, SSB for Sjogren syndrome. Remember, the SLE is a diagnostic criteria, right? So it can be acute cutaneous, the skin is involved, you can have serositis, you can have renal involvement, neurologic, hemolytic anemia, thrombocytopenia, leukopenia. In terms of immunologic criteria, you have ANA, anti-double-stranded DNA, anti-Smith, anti-phospholipid antibody, positivity. Don't forget your complements are low in SLE. C3 and C4, you're low. And you have a Coombs positive direct Coombs test in the absence of hemolytic anemia. So how are we going to treat SLE, right? So you avoid sun exposure, NSAIDs. You give corticosteroids for acute exacerbations. Don't forget that hydroxychloroquine is continued as a preventative measure, even after resolution of symptoms. And hydroxychloroquine is not effective against COVID, okay? Baseline and subsequent annual eye examinations, they are needed because of retinal toxicity. Now, we talked about ANA, right? Anti-neutrophilic antibodies, I think, for ANA. So question, doctors, can you give me conditions in which ANAs are elevated aside from SLE? Where can we see specific elevations of your ANA? Anyone?
Maybe some vascular conditions.
Could you tell me? So RA, rheumatoid arthritis. What else? Scleroderma. What else? Sjogren, right? What else? Mixed connective tissue. What else? Polymyositis, dermatomyositis, and drug-induced lupus. Okay, these are the conditions in which ANAs are elevated. Don't forget those. So common laboratory markers. So guys, there's a high yield table here. Put a star here. Know them well. Those are high yield. Scleroderma. Okay. So in the vignette, don't forget that steroids, they are the best treatment for SLE patients with acute flare. If, however, long-term treatment for SLE, you can give hydroxychloroquine. But be careful. Why? Hydroxychloroquine can cause retinal toxicity. So those are high yield. Steroids for flare, Hydroxychloroquine for long-term treatment, but be careful with retinal toxicity. In terms of scleroderma, you have a chronic connective tissue disorder. The cytokines stimulate fibroblasts, causing abnormal collagen deposition. It is high quantity of collagen, more common in women. Question: the most common cause of death in SLE are what? 2. High yield. The most common cause of death in SLE. You die via 1. Opportunistic infections, and 2. Renal failure. That's it. Clinical features of scleroderma: Raynaud's phenomenon, right? Don't forget, only diffuse scleroderma has renal, lung, and heart involvement. High yield also the HLA associations with rheumatic diseases. Put a star there. Someone talked about, for SLE, antiphospholipid antibody syndrome. This is always associated with SLE. You have recurrent venous thrombosis. That's why you have pulmonary embolism. You have thrombocytopenia. You have livedo reticularis, a lace-like pattern on the skin. Treatment is long-term anticoagulation, right? And you give, don't forget that if you give VDRL testing and RPR to someone who has antiphospholipid antibody syndrome, it can become positive. It's a false positive test. Why? Because the APA antibodies, they react to cardiolipin. What can we see? In scleroderma, in cutaneous fibrosis, you can see sclerodactyly and some GI involvement. So a patient comes in to you, doctors, with Raynaud's phenomenon. Give me differential diagnosis for Raynaud's.
Berger's disease?
Berger's disease, right? Yes, thromboangiitis obliterans. These are disorders that disrupt the blood flow. What else? Certain medications can also do Raynaud's. Example, beta blockers, right? Nicotine. What else? Your chemo drugs, bleomycin, can also do this. Vasculitis. Someone said it. Berger disease, Buerger. Mixed connective tissue disorders, SLEs, scleroderma, and sometimes it's primary. No other disorder exists. Don't forget that the degree of skin involvement predicts prognosis. So if your patient has diffuse scleroderma, it has a worse prognosis than limited scleroderma. Meaning, diffuse scleroderma is worse. So this is your SS, right? No. This is your, this is your systemic sclerosis, SS. Contrast that one with the limited one, which is your CREST syndrome. How are we going to diagnose then SLE? Not SLE. How are we going to diagnose them? SS, systemic sclerosis, high-yield anti-centromere antibody. Very specific, and you have this anti-topoisomerase 1, your anti-scleroderma 70, right? So for drug-induced lupus, right, they are similar. It is similar to SLE, except it does not affect the CNS or kidneys. If renal or CNS involvement is present, it is not drug-induced lupus. What can we see in drug-induced lupus? Antihistone antibodies are always present, although there is an absence of your anti-dsDNA and anti-Smith antibody in drug-induced lupus. So how are we going to compare and contrast your diffuse versus limited scleroderma? As I've said before, limited scleroderma, LS, CREST syndrome, calcinosis, Raynaud's, esophageal motility, sclerodactyly, and telangiectasia. Diffuse scleroderma or SS, systemic scleroderma, widespread skin involvement, you have significant visceral involvement, and anti-topoisomerase 1. It has a poorer prognosis. What's the treatment? No effective cure, unfortunately. NSAIDs for musculoskeletal pains and some symptomatic management, like H2 blockers. For Raynaud's, you use calcium channel blockers, ACE inhibitors to prevent renal hypertension, and then systemic immunosuppression is indicated. So remember, if the patient has a scleroderma, there's a 20% chance that the patient also has Sjogren syndrome. right? In patient with Sjogren syndrome, search for occult lymphoma. So you look for lymphadenopathy and hepatosplenomegaly. Sjogren syndrome, it's an autoimmune disease. What can we see? High yield, dry eyes, dry mouth, right? Along with lymphocytic infiltration of the minor salivary glands. Clinical features, dry eyes, dry mouth, tooth decay, all of that. Arthralgias, interstitial nephritis. How do we diagnose? High yield SSA, SSB, SS, all right? Rho and La. SS signifies Sjogren syndrome. You could also do a Schirmer test, wherein a filter paper is inserted in the eye to measure lacrimal gland output. So don't forget, high yield. Patients with antibodies to Rho, your SSA, are at an increased risk of having a child with neonatal SLE. Therefore, the baby may have like congenital heart block. What's the treatment for Sjogren's? Pilocarpine, of course, a muscarinic agonist that enhance your oral secretions, artificial tears, good oral hygiene and NSAIDs, and if there's secondary therapy for connective tissue disease. What do we mean by mixed connective tissue disease? It's an overlap, similar to SLE, RA, systemic sclerosis, and polymyositis. How are we going to differentiate this one from others? We have the anti-U1 RNP antibodies. That's a key laboratory finding. Rheumatoid arthritis. RA is unlikely if DIPs are involved, or morning stiffness is absent, or joint distribution is not symmetric. Okay, high yield. RA is unlikely, rheumatoid arthritis is unlikely if joint distribution is not symmetric or DIPs are involved, your distal interphalangeal joints, or morning stiffness is absent. So it's not RA. Okay? What is RA? It's a chronic inflammatory disease involving the synovium of the joint. So much of the joint damage ultimately leads to disability. It occurs early in the disease. So early treatment with your DMARDs is very critical. What are the clinical features? Inflammatory polyarthritis, high yield, except the DIP joints. You have morning stiffness that improves as the day progresses. Remember, it's inflammation. So when you use the joint, it improves. Commonly seen in hands and wrist. You can have ulnar deviation, boutonniere deformities of the PIP, swan neck contractures of the fingers. Don't forget that poor prognostic indicators in RA, high RF titers, subcutaneous nodules, and erosive arthritis. You can also have some subluxation and instability where the cervical spine is involved. It's much more common in the upper cervical spine than in the lower cervical spine. This is potentially threatening. Why? Because nerves may be involved. So you should do radiographs before undergoing surgery due to risk of neurologic injury during your intubation. Don't forget, in RA, the changes in the joints are more extensive than in osteoarthritis. Because why? The entire synovium is involved in RA. Note also that osteophytes, which is characteristic of your OA, they are not present in RA. Don't forget that. What else can we see? Ocular involvement, rheumatoid nodules. You can read all of that. Diagnosis, RF titers. The higher it is, the more severe the disease, your rheumatoid factor. Of course, much more specific for RA is ACPA, high yield anti-citrullinated peptide protein antibodies. So let's summarize. What are the extra-articular manifestations in RA? You have B symptoms, malaise, anorexia, weight loss, fever. Cutaneous, you have rheumatoid nodules, which is pathognomonic for RA. Some pulmonary involvement. You have pleural effusions, very common. Cardiac, you have rheumatic nodules, which can lead to heart block. Pericarditis is also very common. Eyes, they have dry eyes, may develop Sjogren. scleritis, scleromalacia. Nervous system, of course, is involved. And felty, don't forget high-yield felty syndrome, which is a triad of RA, rheumatoid arthritis, neutropenia, decrease in neutrophils, and splenomegaly. How are we going to treat rheumatoid arthritis? You can give DMARDs, right? What are your DMARDs? So they should be initiated early. You give DMARDs before you can have the X-ray, before you have X-ray. DMARDs started well before radiographs indicate any abnormality. NSAIDs first, the drug of choice for pain control. However, the best initial DMARD is methotrexate, high yield. So if the question says pain control, it's NSAIDs, right? If it doesn't work, next, corticosteroid low dose. If the question says the best treatment, you give methotrexate. Don't forget the variants of your RA. You have felty syndrome, as I've said, high yield, anemia, neutropenia, splenomegaly, and RA. Don't forget Kaplan syndrome, CAPLAN. This is RA associated with pneumoconiosis. So in order to treat them, you cannot give methotrexate as a monotherapy. It should be combined with other first-line drugs. What are your other first-line drugs? Hydroxychloroquine and sulfasalazine. Don't forget, high-yield methotrexate is the mainstay therapy in RA. Methotrexate is mainstay, and then you add other DMARDs, like hydroxychloroquine and 5-ASA. In severe cases, you can do surgery, like synovectomy and joint replacement. Gout. What is gout? High-yield crystallization of monosodium urate in the joint. Hyperuricemia is a hallmark of the disease. 90% of patients are men over the age of 30. Pathogenesis. Increase production of your uric acid. For example, in Leishman, you have HGPRT deficiency from term 1. You have phosphoribosyl pyrophosphate synthetase overactivity, which increases the cell turnover. Or you have a decreased excretion of uric acid. NSAID diuretics, acidosis, and renal disease. So polymorphonuclears, your neutrophils, they play a key role in acute inflammation of the gout. This develops when uric acid crystals collect in the synovial fluid. So as they develop, the IgGs, immunoglobulin G, they coat the monosodium urate crystals, which are phagocytized by your neutrophils, leading to the release of inflammatory mediators and proteolytic enzyme from the PNNs, which then result in your inflammation. Put a star in this table. This is high yield. How are we going to differentiate osteoarthritis, RA, and gouty arthritis? Read that table. Clinical features, right? Asymptomatic hyperuricemia, acute gouty arthritis. What are the precipitants in acute gout attack? Decrease in temperature if it's too cold, or they dehydrated, or they're stressed, they have excessive alcohol intake, or starvation. You need to do a gram stain and culture of the synovial fluid to rule out septic arthritis, which is the most worrisome diagnosis on your differential. What are the complications of the gout? Nephrolithiasis, although the risk is small, and degenerative arthritis. If you aspirate the joint, what can we see? High yield, needle-shaped, and negatively birefringent urate crystals. The uric acid is not helpful in diagnosis because it is normal even during an acute gout attack. So in an acute gout attack, you avoid aspirin. Why? It can aggravate the problem. Acetaminophen. Why? It has no anti-inflammatory properties. And urate-lowering drugs. Why? Because initiation of this during a flare, it may worsen or prolong the flare. You initiate urate-lowering pharmacotherapy, our allopurinol, for example, once the acute flare has resolved. So first, of course, you avoid secondary courses of hyperuricemia. Tell the patient to avoid the thiazide, loop diuretics. If they're obese, tell them to exercise. If they're alcoholic, tell them to reduce the alcohol intake or reduce their protein intake. Limit red meat or seafood. For acute gout, NSAID is the treatment of choice. Colchicine is also an alternative to those patients who cannot take your NSAIDs. In terms of corticosteroids, so if they do not respond to NSAIDs, all right, and colchicine, you can give them corticosteroids. There's also some prophylactic therapy, like for example, probenecid, sulfonylurea, xanthine oxidase inhibitors, right, to decrease uric acid synthesis, and of course your pegloticase rasburicase, which catalyze the conversion of urate into allantoin to make it much more soluble purine degradation product. So you could use this one as a prophylactic therapy. All right, probenecid, sulfonylurea, your xanthine oxidase inhibitors, and your pegloticase and rasburicase. So the gout, what's the difference with this one from gout? This one has a weakly positively birefringent rod-shaped and rhomboid crystals. That's high yield. They typically occur in larger joints in the knee. Contrast that one with the gout, which is it has a predilection to the great toe of the foot, which is commonly called like podagra. That one. So what's the treatment for pseudogout? Treat the underlying disorder. First line is always high yield NSAIDs, colchicine for prophylaxis, and intra-articular steroid injections. Okay, polymyalgia romatica. This occurs in elderly patients. Commonly, there's a genetic link involved, HLA-DR4 allele. What can we see? Bilateral hip and shoulder muscle pain. You have some constitutional symptoms. However, this is a clinical diagnosis. ESR is elevated, and we treat it with corticosteroids. Contrast that with fibromyalgia. High yield. The key to diagnosis is a multiple trigger points, meaning the points are tender to palpation. So there are 18 characteristic locations, including the occiput, neck, shoulder, ribs, elbows, buttocks, and knees. So it's a multiple trigger points. All of the points are tender to palpation. Sternocleidomastoid, your occiput, your latissimus dorsi, your elbows, right? They are all tender to palpation. What's the clinical feature? Stiffness and body aches. Right? How are we going to diagnose them? Widespread pain, including axial pain. Pain in at least 11 of the 18 possible tender sites. There are no specific confirmatory tests for fibromyalgia. What's the treatment? Amitriptyline, high yield. That's the first line treatment. However, before that, you advise the patient to stay active and engage in low intensity exercise first. Behavior modification first. That's the principle before giving medications, drugs. After that, if that fails, you give amitriptyline. You can also do pregabalin and an SNRI for acute management, or you can also do CBT. Seronegative spondyloarthropathies, ankylosing spondylitis. This is strong association with HLA B27, high yield. How can we diagnose this? Bilateral sacroiliitis. It is prerequisite for making the diagnosis. So you have low back pain and stiffness. You have neck pain and limited motion in cervical spine. So can you give me diseases that belong to the seronegative spondyloarthropathies? Why are they called seronegative spondyloarthropathies?
Can you not find like things in the serum? Maybe I'm not sure.
What is negative?
The
What is
rheumatoid
negative?
factor.
Excellent. So we have negative rheumatoid factor. All of them have a strong association with HLA-B27. All of them has asymmetrical oligoarthritis. All of them has enthesitis. Enthesitis is an inflammation at the sites of insertion of your fascia or ligament or your tendon to the bone. All of them has inflammatory arthritis, specifically the axial bones and sacroiliac joints. They have extra-articular features. You have eye, skin, and GI tract, and they have a familial predisposition. So your seronegative spondyloarthropathies, examples, ankylosing spondylitis. Reactive arthritis, we no longer use the term Reiter syndrome because he's a Nazi. Psoriatic arthritis, arthropathy of your inflammatory bowel disease, and undifferentiated spondyloarthropathy. Just like we don't use the term anymore, the Wegener's syndrome, we call it microangiitis with microscopic polyangiitis, right? Because Wegener, he's a rabid Nazi. So, talk about enthesitis, right? So they improve with activity, actually. NAS, the low back pain and stiffness, they improve with activity. And hot shower worsens with rest or inactivity. So these seronegative spondyloarthropathies, they have extra-articular features. Mainly, they affect your heart and your eyes. High yield. Acute anterior uveitis is most common. You also have heart block and aortic insufficiency. So what if I have ankylosing spondylitis, right? So what? Complications, doctors. Think restrictive lung disease. The lungs can't expand. Cauda equina syndrome. Spine fracture with spinal cord injury. Osteoporosis and spondylodiscitis. How are we going to diagnose high-yield lumbar spine? Either MRI or CT. What can we see there? Sclerotic changes on the sacroiliac area. The vertebral columns fuse. We call it bamboo spine. Of course, the ESR is elevated because it's an inflammatory disorder. What's the treatment? High yield NSAIDs. You can also give etanercept and infliximab, your anti-TNF medications, but be careful. Why? Why do we need to be careful in prescribing anti-TNF medications? You need to rule out what first? TB, right? You need to do a MANTO test, a PPD test, because your anti-TNF medications, they can reactivate your TB. Also, physical therapy, surgery, right? And they must be, if the AS is so severe, the patient needs to be immobilized to prevent spinal cord injury. Now, cross out Reiter syndrome, think reactive arthritis. This is asymmetric inflammatory oligoarthritis of your lower extremities. You have can't see, can't pee, can climb a tree, right? You have arthritis, uveitis, and urethritis. That's it. That's the only thing that you need to know for reactive arthritis. So, doctors, if they're gonna say, like, you need to differentiate the causes of joint pain, whether it's polyarticular, meaning many joints are involved, or monoarticular joint pain. So for polyarticular joint pain, commonly seen in RA, SLE, viral arthritis, reactive arthritis, rheumatic fever, Lyme disease, gonococcal arthritis. For monoarticular joint pain, think osteoarthritis, gout, pseudogout, trauma, septic arthritis, and hemarthrosis. High yield, the organisms usually associated with reactive arthritis include Salmonella, Shigella, Campylobacter chlamydia, and Yersinia. It is a clinical diagnosis. Can't see, can't pee, can climb a tree. What's the treatment? NSAIDs always, first-line therapy. If there is no response, sulfasalazine and azathioprine. Usually, antibiotic use is controversial. It is usually not given. Psoriatic arthritis, If you have psoriasis, you can have this disease. What's the characteristic? High yield, sausage digits, dactylitis, and nail pitting may be present. What's the treatment? NSAIDs. Steroids are not typically used. Did you talk about this one, vasculitis? Or no?
No.
No? Okay, skip.
Yes.
Say pass.
Yes.
Okay, pass. Please don't hesitate to say that. Okay, pass. Polyarteritis nodosa. No, all of the vasculitis, right? Even the ANCA. Okay, now let's go to let's now go to your infectious disease. So if at any point you didn't discuss the topic, just say pass, okay? So that I can skip it. All right, now let's go to infectious disease. Pass or go? Pneumonia? Go. So pneumonia, classic. You have sudden chill followed by fever, pleuritic pain. A typical pneumonia commonly caused by mycoplasma or chlamydia. So for CAP, think strep pneumo. That's the main organism. For hospital-acquired pneumonia or nosocomial pneumonia, think either E. coli or gram-negative Pseudomonas and Staph aureus. How are we going to prevent this one? Influenza vaccine and pneumococcal vaccine. S. pneumo accounts for about like 66% of all cases of your bacterial pneumonia, followed by H. influenzae and then Legionella. So typical CAP agents, as I've said, S. pneumo, the first one, you can read that list. What's the feature? Acute onset of fever, shaking, chills, cough, productive of thick, purulent sputum. You have pleuritic chest pain and dyspnea. In terms of the signs, you can have tachycardia, tachypnea, and pleural friction rub. In X-ray, you have lobar consolidation, and multilobar consolidation indicates a very serious illness. A typical pneumonia, it refers to the organisms not visible on the gram stain and not culturable on a standard blood agar. Don't forget high yield, a good sputum specimen. When you check the sputum, it should have more than 25 polymorphonuclears, your neutrophils, and less than 10 epithelial cells per low power field to consider it a good sputum specimen. Common agents in atypical pneumonia, mycoplasma high yield, that's the most common. You can read the rest. Symptoms, insidious dry cough fever. You have a pulse temperature dissociation. In X-ray, you have diffuse reticulonodular infiltrates. This is called also, a typical pneumonia is walking pneumonia. The X-ray is severe, but physically, they're fine. They're okay. How are we going to diagnose them? Of course, X-ray to confirm the diagnoses. And then check for neutropenia, check for infection with PCP, and check for general disease. Now, as a doctor, you need to differentiate lower respiratory tract infection from other causes of cough and upper respiratory infection. So how are we going to differentiate LRTI and URTI? So if nasal discharge, sore throat, and ear pain predominates, it's URTI, it's upper respiratory infection. And then if you suspect LRTI, lower tracheal infection, you need to differentiate between pneumonia and acute bronchitis. So however, the only thing to differentiate them is not due to your clinical picture, because both of them has cough, sputum, fever, and dyspnea. The only reasonable method of differentiating between the two is via X-ray to differentiate pneumonia and acute bronchitis. So high yield. If a patient comes in, the patient is admitted to the hospital with suspected pneumonia, you should get an X-ray first, always. You should check laboratory tests, CBC differential. You should check O2 saturation, the O2 sat. Check blood cultures. Maybe there's something in the blood. Gram stain, of course, sputum culture, and antibiotic therapy. Usually, radiographic changes and clinical findings, they help in identifying the causative pathogen in community-acquired pneumonia. How are we going to treat them? Of course, it depends upon the gram stain and culture. If it's you need to obtain sputum gram stain for everyone and sputum culture. If it's acid-fast for mycobacterium, if TB is suspected, you can also do silver stain for your pneumocystis pneumonia for HIV immunocompromised patients. If you suspect Legionella, check the urinary antigen assay, high yield for Legionella. You can also have what metabolic disorder here, what electrolyte imbalance in Legionella, hypo or hypernatremia.
Hyponatremia.
Hyponatremia for your Legionella. Okay, acid-fast stain mycobacterium, silver stain pneumocystis carinii, Legionella, urinary antigen assay, hyponatremia. All right, let's do a quiz. Tell me the most common organism. Okay, alcoholics. What causes pneumonia in alcoholics?
Klebsiella.
Klebsiella. In immigrants,
Tuberculosis.
excellent, tuberculosis. Nursing home residents, Mona,
Pseudomonas.
Pseudomonas aeruginosa. HIV positive patients, pneumocystis carinii, right? Organ transplant patients, patients with renal failure or chronic lung disease, Legionella. Okay, those are high yield associations. Alcoholics, Klebsiella, immigrants, TB, nursing home residents, Pseudomonas, HIV positive patients, pneumocystis carinii and tuberculosis, Legionella, organ transplant recipients, patients with renal failure, and patients with chronic lung disease. What's the treatment? How are we going to treat community-acquired pneumonia? Either outpatient or in hospital. You give antimicrobial therapy. Don't forget, in people younger than 60 years of age, the most common organisms are S. pneumo always, then the rest. Okay, so you give macrolides, or azithromycin or clarithromycin, doxycycline to cover all of these organisms. Or you can also give fluoroquinolones. However, penicillins and cephalosporins do not give because they do not cover atypical organisms in this age group. In older adults and patients with comorbidities, you can give fluoroquinolones, levofloxacin, moxifloxacin plus macrolide or erythromycins, or amoxicillin clavulanate as the first line agent. What is this? Amoxicillin clavulanate. Is this augmentin or no? Amoxicillin clavulanate. Does anyone know what this is? If it's augmentin or
I'm not sure.
amoxicillin and clavulanic acid, or amoxiclav. Sorry, this is amoxiclav. Okay, never mind then. So for outpatient, treatment is continued for 5 days, okay? How about for hospitalized patient? You give fluoroquinolone alone or a third generation cephalosporin plus a macrolide. Example, ceftriaxone plus azithromycin. So basically, if they are outpatient, you need to stratify them according to age. Younger than 60, commonly strep pneumo. What can we give? Macrolides, right? Or your tetracyclines to cover all of those organisms. Fluoroquinolones also can be given. Do not give penicillins or cephalosporins. Why? They do not cover mycoplasma. In older and patients with comorbidities, you can give fluoroquine alone plus a macrolide, or you can give amoxicillin clavulanate. You continue this for 5 days until, do not stop it until they have been afebrile for 48 hours. If they are admitted in the hospital, you give fluoroquine alone, or you can give ceftriaxone, which is a third-generation cephalosporin plus azithromycin. All right, how about hospital-acquired pneumonia? So you do ceftazidime or cefepime high yield for pseudomonal coverage. You can also give carbapenem, imipenem, right? However, these are your big guns, right? This is after you only give carbapenems after all of the penicillins has been exhausted, all of the cephalosporins have been done, aztreonam is done. Okay, these are your big guns, your imipenem. And our favorite in the hospital, piptazo, we call this zocin. So you have gram-negative coverage plus a pseudomonas coverage. Piptazo. Of course, macrolides are not used as a single agent therapy. Do not use it. You always combine the macrolide with a cephalosporin. So don't forget, guys, that in pneumonia you have pleural effusions. So what if I have pleural effusions? It can progress to empyema, which requires chest tube drainage. Trust me, it's very, very painful to have a chest tube. Aspirated material is more likely to affect which lung, the left lung or the right lung. If the patient has aspiration pneumonia, which lung is more likely to be affected, left lung or the right lung? The right lung, because the right mainstem bronchus is wider. Okay, good. Then you have ventilator-associated pneumonia. They are being put into vent. But can you see in the X-ray, high-yield new infiltrate? You can have purulent secretions from the endotracheal tube. How are we going to diagnose this one? High-yield BAL, bronchoalveolar lavage. What's the treatment? Again, these are high-yield cephalosporins, or you can do a beta-lactam beta-lactamase inhibitor, your zocin, piperacillin, piperazine, tizobactam, or a carbapenem, last resort, imipen. You can give aminoglycoside, fluoroquinolones, vancomycin, or linezolid. In terms of lung abscess, there are different kinds. There are different organisms that can cause lung abscess, either through aspiration or acute necrotizing pneumonia, your gram-negative rods, or hematogenous spread. Most common are your oral anaerobes, Prevotella, Streptococcus, Fusobacterium, and your Bacteroides. High yield, the most common cause, the main risk factor, is aspiration pneumonia, commonly seen in, oh yes, thank you, Fatima. Augmentin is amoxicillin clavulanate. Okay, I thought I'm just crazy. So, in terms of risk factors, aspiration pneumonia. Think about your patients with impaired consciousness, seizures, alcoholics, dysphagia, neurologic conditions, CVA, right? Or mechanical disruption of normal defense mechanism. If they have NG tube or endotracheal tube. Okay. What are the clinical features? As I've said, foul-smelling sputum. We're gonna put that in the vignette. Shortness of breath, fevers, some constitutional symptoms or B symptoms. In chest X-ray, you can see thick-walled cavitation. You can also have some abscess there. Sputum gram stain is not that, it has low sensitivity and specificity. So how are we going to treat them? Antibiotic regimen, of course. Gram-positive cocci, ampicillin sulbactam, or amoxicillin clavulanic acid. For Staph aureus, for anaerobes, clindamycin, metronidazole. Okay? Continue the antibiotics until the cavity is gone. TB, tuberculosis, the most common cause of death to infection worldwide, caused by Mycobacterium tuberculosis. How are we going? Don't forget, mycobacteria are acid-fast bacilli. Mode of transmission, aerosolized droplets. Pathophys. Inhalation of the droplet, then ingestion of the M. tuberculosis by alveolar macrophages. They survive inside the macrophages. Then you have a granuloma formation to wall off the mycobacteria. Then an insult to the immune system destabilizes the granuloma formation and leads to reactivation. Reactivation only occurs when the host immunity is weakened. You can also have extrapulmonary TB. The risk factors, you can read all of that. High yield, what can we see in the X-ray, right, of your TB? You can see Ghon complex, which is a calcified primary focus with an associated lymph node, contrasted with the Ranke complex, which is a Ghon complex undergoing fibrosis and calcification. Don't forget, diagnosis of TB is challenging in HIV patients because you have a negative PPD, they have atypical chest X-ray findings, sputum is negative, and granuloma formation is not present in late stages. Let's talk about clinical features. Let's talk about diagnoses. How are we going to diagnose? Upper lobe infiltrates with cavitations. Why in the upper lobe? They love oxygen, right? You can also have pleural effusions, Ghon complex. Definitive diagnosis is sputum culture. Always, that's the best answer for the growth of your M. tuberculosis. You need to know what a PPD test is. It's a screening test to detect those who may have been exposed to TB. Know the procedures, please. Don't forget high yield. If patients have previously been vaccinated with BCG, they will have a positive PPD. However, it doesn't affect treatment decisions. We talked about the drugs, the treatment for TB. High yield isoniazid should always be started with vitamin B6 to prevent the symptoms of your B6 deficiency, which includes what? Stomatitis, glossitis, chylosis, convulsions, peripheral neuropathy, and sideroblastic anemia. Yield for a positive TB exposure and positive PPD test, but no active disease, treatment is INH. If the patient has active TB, you can do multi-agent therapy. All TB medications are hepatotoxic. Discontinue treatment if only if liver transaminases rise to 3 to 5 times the upper limit of normal. You talk about influenza?
No, we didn't. You could skip the meningitis.
Okay, pass. How about meningitis? Pass?
No, we did meningitis.
Oh, you did meningitis. Okay, inflammation of the meningeal membranes. High yield, highlight the causes. Neonates, what's the most common organism? Group B strep. Children more than 3 months, Neisseria meningitidis. Adults, strep pneumo. Elderly, strep pneumo. Immunocompromised, Listeria monocytogenes. There's something that's called a septic meningitis, right? This is commonly the most common cause of a septic meningitis is HSV. Don't forget that. High yield. It may be difficult to distinguish from acute bacterial meningitis. So, doctors, don't forget, acute bacterial meningitis, there's a characteristic triad: fever, nuchal rigidity, and change in mental status. Talk about the clinical features. Those are the 3 for your acute bacterial meningitis. You have fever, nuchal rigidity, and change in mental status. Some of them are not specific, like Koenig sign, Budzinski sign, but these are important for OSCE, I think. And you have the JOLT test. However, for the test, the diagnosis is very, very important. Let's see if I put a table here, put a star here. What can we see? CSF findings in bacterial versus aseptic meningitis. In bacterial meningitis, you have an increase in WBC count, Mostly neutrophils, polymorphonuclears, low glucose because bacteria loves to consume glucose, and high protein. Septic meningitis, less WBC, normal glucose, mostly lymphocytes and monocytes. How are we going to treat them? Bacterial meningitis, empiric antibiotic therapy. You give IV antibiotics. If you suspect strep pneumo, you give steroids. Why? To prevent cerebral edema. You vaccinate your patients if they are adults over 65 for strep pneumo, or if they have asplenic patients. For example, your patient who has my God, I'm blanking out. Asplenic patients. What's the most common cause of asplenia? The removal of sickle cell, excellent. And if they are immunocompromised. You can also give prophylaxis, rifampin or ceftriaxone, okay? They're not going to put rifampin because they already know that rifampin is a prophylactic medication. They're going to put ceftriaxone. So don't forget, both of them can be used as a prophylaxis for bacterial meningitis for all close contacts of patients, right? In a septic meningitis, there's no specific therapy other than supportive care. Let's start here. Empiric treatment for acute bacterial meningitis. Know the range of the age, the likely organisms, and the empiric treatment for that. So you can see for infants, group B strep, so we have cefotaxime, cephalosporin, ampicillin, and vanc. For 3 to 50, mostly, and meningitis, so cephalosporin and vanc. For more than 50, you give ampicillin, vanc, and cephalosporin. For HIV, you give cephalosporin, ampicillin, and vanc. So what's the mainstay for all of them? You give cephalosporin for all of them, ampicillin, and vancomycin, basically. So how about encephalitis? What is this then? Encephalitis is a diffuse inflammation of the brain parenchyma. Most common cause high-yield viral herpes. Think about herpes, HSV1. Others are arbovirus and enterovirus. Other non-viral, toxoplasmosis and aspergillosis. Risk factors, high-yield AIDS, of course. Other forms of immunosuppression. What are the clinical features? They have the signs and symptoms of meningitis. They have headache, fever, photophobia, nuchal rigidity. They have altered sensorium. They have confusion, delirium, disorientation, and behavioral abnormalities. It's very vague. How do we diagnose them? Check laboratory testing. Perform LP to examine the CSF. So lymphocytosis with normal glucose is consistent with viral encephalitis. That's high yield. The most specific and sensitive test for diagnosing the viral encephalitis is CSF PCR. You need to get the cerebrospinal fluid and put it in a polymerase chain reaction. What's the imaging of choice? The gold standard for imaging, MRI of the brain. High yield. Why? Because you can rule out any focal neurologic causes such as your abscess. Okay, I have a question for you guys. Not all brain abscesses are bacterial, especially in immunocompromised hosts. So could you tell me the organisms that can also cause brain abscess in immunocompromised hosts? Come again, please. Toxoplasma gondii, right? Don't forget that. What else? Candida.
Oh, sorry.
Go ahead.
I don't know. I just said Tinea solium.
So your fungi, right?
Yeah.
Yep. Candida. Don't forget. There's another one. Invasive aspergillosis. Your aspergillus, and zygomycosis in your neutropenic patients. So what's the treatment then? Since it is viral, right? So you give antiviral therapy. High yield. HSV, acyclovir. CMV, ganciclovir or foscarnet. Careful. Why? Nephrotoxic. So you manage possible complications. If there's seizures, you give anticonvulsants. If they have cerebral edema, give mannitol for osmotic diuresis. Chlamydia, did you talk about this?
You can skip it.
Oh, skip, okay. Skip. Gonorrhea.
And it was more 24. Yeah.
Okay, so nothing there, you know that already. HIV.
Yeah, this one
Same.
about
Skip, no.
no.
Okay, so let's talk about this. Is a very high yield topic, right? So we just celebrated Valentine's Day. In honor of that, let's talk about sexually transmitted sexually transmitted sexually transmitted diseases, guys. Of course, always, right? Use protection. So, HIV and AIDS. So what's a pathophys? HIV is caused by HIV type 1 human retrovirus. So they attach to the surface of the CD4 T lymphocyte, they enter the cell, they uncode, and the RNA is transcribed to DNA via your reverse transcriptase. Therefore, you have the CD4 cells are being destroyed by your HIV type 1 human retrovirus. So this depletion of CD4, it weakens your cellular immunity. Whilst the transmission, sexual, of course, or parenteral, right? Other than semen and the blood, fluids that transmit the disease are breast milk and vaginal fluid. Look at the risk of transmission. Needle stick injury, so us doctors, right? 1 in 300. Vaginal, male to female, 1 in 1,000. Vaginal, female to male, 1 in 3,000. Anal receptive, look, 1 in 100. Look at the incidence there. Look at the risk. Mother to child, 1 in 3 without medications. So the most common, basically, the risk of transmission is anal receptive, right? Because it's 1 in 100, followed by needle stick injury, 1 in 300. So I yield for HIV serology. Let's talk about the Cd4 cell count. This is the best indicator of the status of the immune system and the risk for opportunistic infection. Why are we monitoring the CD4? It is used to determine when to initiate your antiretroviral therapy and PCP prophylaxis, your thermethoprim sulfamethoxazole. It is also useful in assessing the response to your antiretroviral. You also need to check the viral load. The viral load, or your HIV-1 RNA levels, this is used to assess response to the antiretroviral therapy. So it provides like a complementary prognostic information to the CD4 positive count. Again, the course of HIV, it's different from one patient to another. However, we can divide them into 4 phases. You have primary infection, then asymptomatic, followed by a symptomatic infection, a full-blown AIDS. The combination of ELISA and Western blot, it yields an overall sensitivity of like 99%. So the combination of them is good. But now we no longer use ELISA and Western blot. We now use PCR, I think, for diagnosing HIV. What are the clinical features? You should know them. Primary infection, it's like constitutional B symptoms, it's like mononucleosis, EBV, you have fever, sweats, malaise, lethargy, asymptomatic infection, then you have the symptomatic HIV infection. You can read all of that. Diagnosis, this one is yield PCR RNA viral load test, of course. P24 antigen, however, this is like less sensitive, so don't do that. Do the PCR RNA. We no longer use ELISA and Western blot. So how are we going to diagnose like AIDS? So the patient with HIV has AIDS if he or she has one a CD4 T cell count below 200, and an AIDS-defining illness. Do I need to know the clinical manifestations of AIDS? Yes. It's all on this table. Put a star on that table. The leading cause of death in patients with AIDS is PCP. It occurs when CD4 count is 200. All right. If the CD4 count is 50 high yield, it's CMV or MAC, Mycobacterium avium complex. That's also high yield. For nervous system, think toxoplasmosis. So you have ring-enhancing lesions in the basal ganglia and subcortical white matter. Cryptococcus, don't forget, India ink for your cryptococcus. You treat with amphotericin B, followed by oral fluconazole. Sometimes fluconazole therapy is indicated for life. Gastrointestinal thing is of candidiasis for this one. Highlight that. Also CMV and HSV if the CD4 count is less than 100. Kaposi sarcoma, this is very important, HHV 8 for this. And for others, you have a Mycobacterium avium complex. Put the highlight there. If you have fewer than 50 CD4 cells. All right, how are we going to treat them? What's the antiretroviral therapy in HIV? We talked about this last Sunday. You can give like triple drug regimen, HART. You can give non-nucleoside reverse transcriptase inhibitors. You can give a protease inhibitors, NRTIs, and NRTIs. You can give those. However, the most important thing to tell the patient is strict adherence to the medication, right? Because even minor deviation may result in drug resistance. Okay? So, doctors, do not initiate HART therapy in a patient who is not willing or able to fully comply with the prescribed regimen. Okay? If they are not willing, do not give it to them. Opportunistic infections for PJP. What's the test? Chest X-ray. High yield, what's the treatment? Trimethoprim, sulfamethoxazole. For TB, we talk about that. Isoniazid, vaspiridoxine. For atypical, for MAC, clarithromycin and azithromycin, your macrolides. For toxoplasma, Bactrim, trimethoprim, sulfamethoxazole. High yield, no live virus vaccines, right? But you can give pneumococcal, polysaccharide vaccine, influenza, and hepatitis B vaccine. Okay. Question. Can you give me like diseases that indicates AIDS? If you have this disease, probably you might have AIDS.
Candida? Like esophagitis, Candida?
Okay, good. Invasive candidiasis. What else?
PCP.
PCP. Good. What else? Kaposi sarcoma. What else? Tuberculosis. Can be. Toxoplasma. Can be. Histoplasmosis. Go ahead.
Mycobacterium avium.
Excellent. MAC. Sometimes CMV outside, lymphoreticular system. Encephalopathy also, HIV related. You can have that. Sometimes coccidioidomycosis. Extrapulmonary manifestation can be. It can indicate AIDS. Herpes simplex if you have more than 1 month duration of visceral herpes simplex. Recurrent salmonella infection, and also do that one. Kaposi sarcoma, of course. Lymphoma. What else? PMLs. You have the personality changes, right? And wasting syndrome. Good. Did you talk about herpes simplex?
Yes.
Okay, so put a star here for antiretroviral therapy. I think that's very, very important. Know the mechanism. It's listed here. It's listed here, and then know the mechanism and the toxicity. So HSV 1 and 2, there's different. 1 in the mouth, 2 in the genitalia. But we humans, we are very creative. So we can get either 1 and 2, right? Typically, HSV1 is in the mouth and HSV2 is in the genitalia. But, you know, we humans are very creative. So pathophysiology, what's the pathophys for your HSV? It replicates in the dermis and then it travels to the dorsal root ganglia. So boys and girls, make sure that the person you get the HSV is the person you're gonna marry and spend the rest of your life with. Why? Because this disease is forever. Why? It goes up to the dorsal root ganglia. So it goes there, it marinates there, and then you have reactivation. So, how is this transmitted? Contact. If you have active ulcerations or shedding of the virus. All right, the incidence of HSV2 has increased in recent years. So, in honor of Valentine's Day, look at that. This is an example of a herpes simplex virus. So, you can have genital ulcers with regional lymphadenopathy. There are different kinds of lesions. This is like herpes simplex viral lesions. Clinical features of HSV1, since it's oral, obviously you have oral lesions. You can have vesicles and patches of erythematous skin, cold sores, most common on the lips. Don't forget, HSV1 is associated with Bell's palsy. So reactivation of HSV1, Bell's palsy, facial nerve palsy, cranial nerve, 7. HSV2, it's in the genitalia. So you have prolonged symptoms, you have constitutional symptoms or B symptoms, and you have painful genital vesicles or pustules. Don't forget, I've seen a question. They showed me like a picture of a hand, and what's in there are you have vesicular lesions there at the fingertip. We call this one herpetic whitlow, which is HSV infection of the finger caused by inoculation into the open skin surface. It's painful, it erupts at the fingertip, it can cause fever and axillary lymphadenopathy. What's the treatment? It's herpes, so you give acyclovir. Okay? Acyclovir. What if it's disseminated? What can you give? Disseminated HSV is rarely, and pregnant women may develop disseminated HIV, which can be fatal to the mother and the fetus. It can result in a lot of disorders. How do we diagnose? Zank smear is the quickest test, high yield. However, the gold standard is culture of your HSV. You can also do direct fluorescent assay and ELISA. Is there a treatment? No cure, as I've said before, for either type of your herpes simplex, and antiretroviral treatment provides symptomatic relief. For mucocutaneous disease, you treat acyclovir, valacyclovir, and famciclovir if to have better oral bioavailability. You can also give oral acyclovir and foscarnet if they are resistant in immunocompromised patients. Syphilis, did you talk about this?
No.
No, skip.
Yep.
Tell me when to skip, please. Ancroyd.
Oh, we spoke about like the treatment for syphilis and stuff.
For syphilis, antibiotics, right? Benzathine, penicillin, right? 1 dose IM. If the patient is allergic to penicillin, give tetracycline. Okay? If they have a latent syphilis or tertiary, Syphilis, a disseminated one. You give penicillin in 3 doses IM. Okay? You repeat the test every 3 months to ensure adequate response to treatment. So syphilis, think benzathine penicillin. GIM, 1 dose. That's the preferred agent. If allergic to penicillin, give tetracyclines, doxycycline. Chancroid, Haemophilus ducreyi, painful genital ulcers. You can have buboes. What's the treatment? Macrolides. You can give azithromycin, erythromycin, or you can give ceftriaxone, IM, 1 dose, or ciprofloxacin. An example of chancroid. Very painful. You do cry. Haemophilus ducreyi. This one is caused by chlamydia trachomatis. Treatment is doxycycline. You talk about pubic lice. No, just say skip.
Yeah.
Skip.
Osteomyelitis.
Skip.
So this is one of the musculoskeletal. That's why I put it here. Osteomyelitis, commonly seen in open fractures. So guys, put a star here. Common bugs in osteomyelitis. This is high yield for the staph. For catheter, Staph aureus. For prosthetic, coagulase negative staphylococci. Diabetic foot ulcer is polymicrobial. There's no one organism that is responsible if the patient has diabetic foot ulcer. For nosocomial infections, always Pseudomonas. For IV drug use, think fungal and Pseudomonas. For sickle cell, high yield, it's always Salmonella. Okay, put a star here. If this doesn't appear in your exam, it's very high yield on the step. Clinical features, you have pain in the bone, diagnosis, WBC count, ESR and CRP are very important in monitoring the response to therapy. Don't forget that Mycobacterium tuberculosis, it can have extra pulmonary manifestations, and one of them is osteomyelitis of the vertebral body. We call this one pot disease, okay? That's high yield. For osteomyelitis, we need to have the most direct test is needle aspiration. We need to aspirate the bone to actually see the organism itself. MRI is the most effective imaging study for diagnosing osteomyelitis and assessing the extent of disease. Treatment, IV, antibiotics. You give cephalosporins, fluoroquinolones, and all of those good stuff. Rifampin can also be added as an adjunct. Why? To help with biofilm penetration. You can also give an aminoglycosides, your gentamicins, and a beta-lactam antibiotic. Lastly, don't forget surgical debridement of the necrotic bone. This is very, very important. You talk about arthritis, acute infectious arthritis.
Yeah.
So this is when the bacteria, they invade the joint space. Hematogenous spread, that's the most common route. There's a microbiology high yield, Staph aureus, that's the most common in adults and children. Gonococcal arthritis is the most common cause in young sexually active adults. So check the vignette, okay? If it's young sexually active adults, it's by Neisseria gonorrhea. Okay, some also has like gram-negative, like Pseudomonas and Salmonella. If there's a history of sickle cell, think about Salmonella. Okay, other risk factors, you can read that one. What are the clinical features? The range of motion is very limited. How do we diagnose? You perform a tap, you analyze the synovial fluid. What is in there? Increase in WBC. Of course, culture, both aerobic and anaerobic bacteria is present there. You can also do PCR of the synovial fluid. Blood cultures are positive. Other tests, leukocytosis, of course, there's inflammation. WBC is increased. Elevated ESR and elevated C-reactive protein. These are your non-specific markers of inflammation. Don't forget ESR and CRP. So if there is inflammation, they should be increased. Imaging studies, plain radiographs, CT, MRI. What's the treatment? Antibiotics. So for antibiotic therapy, you start with broad spectrum, pending the result of your diagnostic studies. When you have now the result of the diagnostic studies, you narrow it down. Okay, so basically in the hospital, we give Zosyn, piperacillin tazobactam. So it covers gram-negative and Pseudomonas. So we start big, pip-tazo. And then when the diagnostic studies comes, the culture and sensitivity, it says, okay, it's sensitive to this. And then we discontinue the Zosyn, and then we do like the specific, so that we narrow it down to the actual organism itself, right? So you can do drainage also, like daily aspiration of the joint. Lyme disease. Lyme disease, if you are from the Northeast, like myself, Massachusetts, right? From Maine to Maryland, or from the Midwest, Minnesota, Wisconsin, or from the West Coast, Northern California, Lyme disease is very, very common. Peak incidence, summer. Transmission, Borrelia burgdorferi by the tick, Ixodes scapularis. So what can we see in the skin? Erythema migrans, right? And there's a vaccine actually for Lyme disease. However, it's taken off the market because of the lack of use. No one is using it. Erythema migrans, this is the hallmark skin lesion. This is your target shape lesion. And then it spreads. Second part, you have flu-like symptoms, headache, neck stiffness. Then you have meningitis, encephalitis. Within weeks or months, AV block is the deadliest of them all. You can have a heart block. And then for late, you have chronic CNS and a rare skin lesion. It's an example of your target lesion, your erythema migrans. Diagnosis clinical, and you can have serological studies for Lyme disease, ELISA, to detect your IgM and IgG. In terms of the treatment, doxycycline. You can also give Amox and cefuroxime for alternative agents. Don't forget that macrolides may be given to pregnant patients with penicillin allergies. They are safe in pregnancy. Treatment complications, like facial nerve, your Bell's palsy, arthritis, and cardiac disease. Sometimes they develop meningitis, so you might give IV antibiotics for 4 weeks. You talk about Rocky Mountain spotted fever. No, this is term 4.
Yes, we did.
Oh, you did. Okay, common cause, Rickettsia rickettsii. So the tick is feeding on various mammals as vectors. Endemic areas, you can read that. What's the pathophys? So the organisms enter the host cells via tick bites, and then it multiplies in the vascular epithelium. Clinical feature, high yield. Rash starts peripherally and then spreads centrally. So they start on your wrist, forearms, then it spreads central. It can lead to pneumonitis. Right? Diagnosis clinical. What's the treatment? Again, doxycycline. So you see the pattern, right, guys? So if it's an intracellular pathogen organism, you always give tetracycline, whether it is Borrelia, whether it is anything that has intracellular pathogen, you always give tetracyclines. If CNS manifestations of pregnant patients or pregnant, you can give chloramphenicol. Put a star here. This is important. It's just a table of your zoonosis and arthropod-borne diseases. Leptospirosis, right? In the vignette, surfing in Hawaii. Think leptospirosis, contaminated water. Then they have anecteric rash. They have increase in LFTs. What can you give? It's a spirochete. It's an intracellular pathogen. So you give tetracyclines, you give doxycyclines. Ehrlichiosis, intracellular gram-negative, tick bite by a deer. They have renal failure, GI bleeding. What can you give? Tetracycline again. It's an intracellular pathogen. See the pattern? Tularemia, Francisella tularensis, tick bites, reservoir rabbits. You have fever, ulcer at site of the tick bite. What can you give for tularemia? You can also give doxycycline, but here the treatment is gentamicin, your aminoglycosides. For Q fever, organism, Cibernati, transmission blood, infected milk, farm animals. What can you give? Again, doxycycline or fluoroquinolones. If it's chronic, you can give rifampin. And cat scratch, Bartonella, Penicillin, scratch from a cat. What can you give? Doxycycline or ciprofloxacin. Know the disease, know the organism, transmission reservoir, findings, diagnosis, and treatment. This table is very high yield. In terms of candidiasis, Candida albicans, yeast infection in the vagina, cabbage, cheese-like vaginal discharge. You can have like a thick mucocutaneous growth. Also in the mouth, it can cause thrush. You can have cutaneous candidiasis. GI tract, you can have Candida esophagitis. And dissemination occurs in immunocompromised hosts. So this is an example in the axilla of cutaneous candidiasis. How do we treat them? Clotrimazole, nystatin, high yields, which we should swallow. For oral candidiasis, for esophagitis, ketoconazole or fluconazole. However, if you give ketoconazole to men, what happens to them? If you give ketoconazole to
Gynecomastia.
excellent. So they can have gynecomastia. So be careful, right? So what's the treatment? If we talk about that's for vaginal candidiasis, like a cream, miconazole. For cutaneous, oral nystatin powder. For systemic, use the big guns, amphotericin, amphotericin B, or fluconazole. You can also give alternatives like foriconazole and Caspo. So aspergillus or aspergillosis, right? So this one, you have ABPA. You need to know this one. This is high yield. Allergic bronchopulmonary aspergillosis. It's a type 1 hypersensitivity reaction. What can we see? Asthma and eosinophilia. That's it. Invasive aspergillosis only occurs if you have like immunocompromised, like AIDS patient. And pulmonary aspergilloma only occurs if you have your patient is infected with TB, you have the cavitation there, the aspergillus species can grow in that cavitation. That's pulmonary aspergilloma. What's the diagnosis? You can see a fungus ball, high yield. What's the treatment? Corticosteroids, right? For ABPA, they should avoid exposure. For pulmonary aspergilloma, lung lobectomy. We remove that infected lobe. For invasive, go for the big guns, amphotericin B. If like surgery may be required if there's like a brain involvement. Cryptococcus neoformans, pigeon droppings, think about advanced AIDS. So you have meningitis and meningoencephalitis. What's the diagnosis? The tissue biopsy has no lack of inflammatory response. And LP in lumbar puncture. This is essential. You can see in India ink smear to show encapsulated yeast, high yield. What's the treatment? High yield amphotericin with flucytosine for 2 weeks followed by fluconazole. Sometimes they have lifelong therapy of fluconazole. So it depends on your CSF cultures. Put a star here. Overview of your systemic mycosis. Histoplasma, commonly in Ohio River Valley, ulcers on the mouth, histology macrophages filled with fungus cells. What can we give? Antifungals. You can also give amphotericin B. Coccidioides, commonly in southwestern US, erythema nodosum and erythema multiforme. You have spherules, larger than red blood cells filled with endospores. Blastomycosis, Eastern US, varicose skin lesions, broad-based BBB, blastomycosis B, broad-based budding yeast. Paracoccidioidomycosis, they love this one, Latin America. You have a budding yeast larger than RBCs, and they look like a wheel, a cogwheel. for this, for paracoccidioidomycosis. You can give amphotericin B for all of them. You can also give voriconazole and caspofungin. In terms of the protozoa, this one, Toxoplasma, Naegleri, Trypanosoma, Acanthamoeba. Know them. There's a DLA of the treatment for the protozoa. Most of them are like albendazole, mebendazole, right? Know the specific treatment for them, please. But most of them are, so as I've said, like mebendazole, albendazole, all of those azoles. Infectious mononucleosis, this is EBV. Kissing disease, put a star here. This is high yield, the common organisms in various infections. In your exam and for step 1, you need to know the most common. If it's pneumonia, if it's CAP, if it's typical, S. pneumo, atypical, chlamydia, nosocomial, S. aureus. For aspiration, always oral anaerobes, your Klebsiella, right, Enterobacter. UTI, most common is E. coli. If a sexually active female, is Staph saprophyticus. Osteomyelitis, septic arthritis, always S. aureus. However, if they're young and sexually active, think Neisseria gonorrhea. For surgical wound, think Staph aureus. Diabetic ulcer, commonly polymicrobial. Okay, for that one. If it's intravenous catheter, S. aureus or Staph epidermidis. Cellulitis, S. aureus. Necrotizing fasciitis, C. perfringens, Clostridium. For upper respiratory pharyngitis, is always viral. For chronic sinusitis, S. aureus. Endocarditis subacute, Strep viridans, acute. If there are IV drug users, S. aureus gram-negative rods or Enterococcus. If it's a prostatic valve, then Staph epidermidis. For gastroenteritis, mostly viral. You should know all of that. For intra-abdominal, think about your gram-negatives, right? Your Enterococcus, Bacteroides, and E. coli. All right, we'll talk about clinical features of your EBV, fever, sore throat, myalgias. You can have lymphadenopathy, hepatomegaly, and palatal petechia, and eyelid edema. You can do the monospot test, high yield, heterophile antibodies. You can also do EBV specific antibody testing. Complications, you can read that. What's the treatment then? This is important. Tell them to avoid strenuous activities. Why? Splenic rupture, to prevent splenic rupture. You give NSAIDs to reduce temperature and pain. All right, thank you so much for spending the time with me tonight. And if you have any questions, you can always message me privately, or you could put your questions on our Facebook page. So good luck on your exam, good luck on your OSCE, good luck with everything. And remember, I'm always here rooting for your success, okay? On to clinicals, on to step 1. All right, have a good night, guys.
Thank you so much.